Okay. Okay. Good afternoon, all the delegates. Good afternoon, MSDC speaker. And first of all, welcome and thank you, all of you, for supporting this our activity, which has been planned today. And this activity is been planned with the help of Academy of Dental Careers Inclusive ADC, Inclusive Dental Ozone, Dr. Sudhir Dole and his team, and we are there since last many days rather. And probably this is third and fourth activity. Probably we are conducting along with MIDSR Dental College, Latur, and henceforth also will be conducting many activities. So thanks to ADC team, all the ADC team. Then just a minute. I think it's hang up. This is our college, the other team, that is MIDSR Dental College, Latur.
क्या हुआ?
And this MIDSR Dental College, Latur, has been established in 2006, and it has got this thing, a medical college campus along with physiotherapy and nursing college is there. And probably in short time we'll be starting a Ayurvedic college also. And this is well established, and we are running PGs, nearly 6-7 branches in our institute. This is our founder president, respected Dr. Vishwanath Karad sir. Is a prominent Indian educationist and a visionary and a founder of the MIRS MIT Group of Institution, Pune, which includes the MIT World Peace University, that is MIT WPU. He is also a proponent of a World Peace, a UNESCO chairholder for human rights, democracy, and peace, and a creator of the World Peace Dome. His mission is to promote value-based universal education and establish a culture of peace globally, combining scientific and a spiritual component of the life. So he is our founder president. Respected Dr. Rahul Karad sir. He's executive president of MIRS MIT Pune, and carrying forward a glorious legacy of revered Professor Dr. Vishwanath D. Karad. Dr. Rahul Vishwanath Karad serves as a managing trustee and executive president of MIRS MIT Group of Institution, which encompasses more than 70 institutes and nurtures over 80,000 students. He's an engineering graduate and a postgraduate in the management from the Cardiff University, UK, and an alumnus of a Harvard Business School, USA. Dr. Rahul Karad is dedicated to the nation building through youth empowerment. His vision is to help young minds realize their full potential through holistic and value-based education. The Institute, MIDSR Dental College, Latur, the executive director, respected Dr. H.T. Karad sir, what he is known for a principled and a disciplined approach, and he is teaching us since beginning, and probably henceforth also he will be teaching us and guiding us in the same way to achieve our goals. Respected Dr. Suresh Kangane sir is a principal, MIDSR Dental College, always supportive to the new ideas and helping all the researchers, all the students, all the faculty members in all the directions in what all sense they want to develop the education. A hardworking vice principal, respected Dr. Yatish Kumar Joshi sir, who is a vice principal. I always call him not only vice principal, but a voice of a principal too, and probably helping in all sense to develop the research, all the activities at our college. This is what is a recent loss to our faculty. The most of the senior members, like the all the oral medicine specialists, must be remembering him. Dr. Balaji Rao recently passed away. He was a senior oral medicine specialist and a towering genius in our OMR fraternity, a loss which cannot be filled. And this is what his remembrance on this occasion. Then coming to the today's this thing, it's today's World Radiology Day, or Roentgen Day. It's 130th anniversary of discovery of X-rays. This has been shared by respected Dr. Shailesh Lelesal. In short, about William Conrad Roentgen and what he has discovered, and in short about his work. Roentgen discovered X-rays during experiments with cathode rays in University of Würzburg in today's Germany. After extensive research and experiments, he identified almost all the properties of X-rays and published his discovery on 29 December 1895, made the first ever medical radiograph of his wife's hand, gave his only public talk on the discovery on 23rd January 1896, and took an X-ray of Albert von Killer, an anatomist's hand, awarded honorary doctor of medicine by University of Würzburg, received a Rumford Medal from British Royal Society, published 3 papers on X-ray. Roentgen honored with the first ever Nobel Prize in physics in 1901. In short, about his life, born on 27 March 1845, attended Utrecht Technical School and expelled from the school for a prank, joined a polytechnic school in Zurich and received diploma in engineering, received a PhD in 1866, appointed as a professor of physics at University of Würzburg 1888, married to Anna Bertha in 1872, a very honest, straightforward investigator, a fine experimentalist, and an outstanding teacher. Never patented his discovery to make it freely available to mankind, donated his Nobel Prize money to university for research, felt dejected by the wanton commercialization of his degree, and died of a cancer in 19 February 2023. This is what is his radiograph is being taken. This is the first ever radiograph was taken in Germany. Dental radiograph was taken, and this is a birthplace, workplace, and a final resting place of the Sir William Conrad Roentgen. We all salute him today on 130th anniversary on this discovery. And again, thanks to respected Dr. Shailesh Lele sir, who has visited his place and shared all the information. Now, this is what sir has shared. All of you, please see just 1 minute video. Sir had visited the Roentgen's lab, and he has taken a radiograph, the video there, and he has seen the way he was working. It's just only a small video which will highlight his work. This is his lab. And we all thanks Dr. Shailesh Lele sir from the team MIDSR and ADC. And I'll just run the video again once again. Where actually the X-ray discovery had occurred exactly 130 years back before this. Okay. Yeah. So all the instructions are being given to you, and probably I think it's a time that we'll start with our program immediately. And before starting the program, first short introduction to our MSDC observer today, Dr. Pratik Parkarwar sir is there. Dr. Pratik Parkarwar sir is working as a reader in PDU Dental College, Solapur. He has got some numerous book publications. Even now, I don't know the number, and even if I tell that number, the number will be increasing. He's a postgraduate teacher also. He's a PhD scholar also. He's a very good friend of me. And plus, recently, I think he's got some patent also that yet now it has been not published. And we welcome Pratik Parkarwar sir, and we congratulate him on this occasion also. Right?
Thank you, sir.
Now, yeah, we'll directly, without wasting our time, we directly will go to our first topic. And respected Dr. Mahendra Patait sir is already with us. And this is again my honor and my pleasure to introduce my friend and my mentor also, because he's been helping in many hand also, and the way he was ready with for giving the lecture within a short period of a time, that only one friend can do it. So this is my really honor, and that I'm welcoming Dr. Mahendra Patait sir. A long biodata, MDS, DHM, PhD, MBA Fellow, CBCT UK. He is the head of the Department of University Research Department. This is my great honor and privilege to introduce Dr. Patait sir, who's an esteemed oral diagnostician, distinguished maxillofacial radiologist, and exemplary researcher in the field of healthcare sciences. Dr. Patait's distinguished journey through academia and clinical practice reflects his relentless pursuit of knowledge, his unwavering commitment to the advancing dental science, and his dedication to fostering groundbreaking research. Dr. Patait began his academic journey by completing his bachelor degree at the prestigious Government Dental College and Hospital, Mumbai. He further pursued a master degree in dental surgery, which he completed in 2002, and continued his academic advancement with PhD in the dental sciences. A PhD in the dental sciences. His thirst for knowledge led him to undertake specialized training, earning a fellowship in Conebeam City from London Academy of Dentistry, UK. Additionally, he holds an MBA in Hospital Management and a Digital Health from the esteemed Empirical College of London, along with certifications in clinical research and a diploma in artificial intelligence and augmented reality. In his pivotal role as a head of the University Research Department at MUHS, where over 560 healthcare institutions are affiliated, he plays a critical role in shaping the future of dental education, research, and practice, both nationally and globally. Dr. Patait currently serves as a Joint Director of Indian Academy of Oral Medicine and Radiology in Maharashtra and a Central Research Board member at Maharashtra University of Health Sciences, that is MUHS. Commencing in his teaching career in 2003 as a lecturer at GDC Nagpur, Dr. Patait now holds the esteemed position of professor, postgraduate guide, and PhD guide with a special focus on 3D technology in the medical sciences. His dedication to mentoring has influenced countless professionals, instilling in them not only the academic knowledge, but also a strong drive for innovation and research. As prolific researcher, Dr. Patait holds 5 patents, 6 published books, more than 300 IPR copyrights, 30 IPR copyrights, and has contributed, probably that number will go on 300, we never know, has contributed over 52 articles to the national and internationally indexed journal. His research encompasses a diverse range of pioneering topics, including the application of 3D vision using Conebeam CT with groundbreaking contribution to the diagnostic technologies and clinical treatments. In addition to his academic and research role, Dr. Patait's expertise in imaging guided implantology enables him to provide state-of-art of the clinical care. His exceptional work has earned him invitations to speak at a prestigious global conference such as International Association of Oral Medicine and Radiology Conference and the International Conference of Dental Imaging, CAD/CAM Dentistry in Dubai, UAE. Dr. Patait's outstanding contributions have been recognized through numerous accolades, including the most proactive academicians of the year 2015 by Guidant Delhi and the Research Excellence Award 2020. In conclusion, Dr. Patait's multifaceted career as a researcher, educator, academician, and clinician serves as a true inspiration. His relentless commitment to the advancing research and his continuous pursuit of innovation have solidified his position as a leading figure in the field. Please join Dr. Patait, sir. We welcome you, sir. And whatever the biodata is there is something very less. Probably you must be having something more, and we are not knowing. Now it's over to you, sir. Dr. Patait, sir.
Yeah.
You can take
Thank you, Dr. Abhay. Thank you so much. Actually, I just cut shorted that, and I suggested you just to introduce me as a research head. That is the prime role at present I'm playing. But being a dentist and oral radiologist, I do have a lot of soft corners for the radiological part. And when I came across the guided implantology, I prefer that let's have a sharing of the knowledge of that with all the budding dentists, because I feel that mixed crowd is there. Maybe undergraduates, postgrads are available, and most of them are quite aware of the CBCT now.
Yes.
So I'm just taking them to the next level where the guided implantology is really playing a well role as far as dentistry is concerned. And guided implantology, no doubt, it's a conversion of the conventional radiological knowledge and implantology knowledge. So just allow me to share my screen so that I can continue with my presentation. Yeah, I think it's visible.
Yes, it is visible.
Yeah, thank you. Thank you so much. I'll just go to the presentation mode. Very wisely suggested by Dr. Abhay also that why not to go for the 3D rather than the imageology. Let's go for the beyond the imageology rather than 3D. What I generally prefer that diagnose, decide, and then deliver what patient is expected as far as edentulous area is concerned. Being a dentist and oral diagnostician, no doubt we are deals with the different diseases, different pathologies of the oral cavity, along with our colleagues like oral pathologists and oral surgeons. But being oral diagnostician, and we can see through and through to the own area, why not to come somewhere where the booming branch, where the implantology is taking care financially and education wise a different step. So 3D planning for 3D precision. So I'm just trying to redefine the implantology through the radiologic guidelines or radiographic presentations. So we have that CBCT, that is cone beam computed tomography, as most of us are quite aware of what that technology exactly is. So how to get implement in the clinical practice, being a dentist, and consider it as one of the bread and butter for clinical practice also. So let's open up the mind for this when we are entering the clinical practice or being a PG students or at the undergrad level. Why not to diagnose the case in the 3 dimension? Speaking to these particular projects, as far as CBCT, I always came across this particular idea that real voyager of the discovery consists not in making a new landscape, but in having a new eye. So everybody has the sight, but nobody may not have that much of the vision to go through that idea. So let's look beyond the ideas and conceptualizing that ideas into practicality. So 3D in the dentistry, diagnosis to designing and then delivering that particular. So this is the welcoming the era of the 3D, which is based on the volumetric tomography. As volumetric tomography is a volume where we can able to analyze length, width, and the depth of a pathology or a edentulous area in a tomographic way. Tomography is a section of a particular areas. So I'm getting you more in advanced area, assuming that most of us know what exact radiology is there and what is 3D imaging is there. So digital dentistry is all about a traditional knowledge. It is nothing new, but it is just, we can say that the old knowledge in a new book. That is the 3D dimension we are coming across. And what 3D knowledge or traditional knowledge we are having, we are just trying to apply in a better way, in a digital way. So just that a CBCT technology where we can accurately visualize the hard tissue and less accurately, maybe the visualizing only the image, or we can see the border lines of the soft tissue in the head and neck area. So that idea we are having now. And as we know that CBCT is giving us a different section, and we can visualize the area of interest either in the frontal view, either in the lateral view, or from the top view, or you can label it an axial view. So anything, because this concept you should understand and applied in your clinical practice, because we are dealing with the 3-dimensional words. That patient is in 3-dimensional area, our instruments also in the 3-dimensional. So why not to get pathological analysis in a 3-dimensional way, so we can convince the patient more clearly and the pathology can be treated by looking at its complexity and going ahead with the better outcome and prognosis of disease. So this is the 3rd dimension where the radiology is playing a crucial role. But generally, when we are having the IOPAs and we know the X-rays, why there is a need of the 3rd dimension. So just get clear up our mind block in this, because two-dimensional, this great person was taken in 1896, first radiograph was taken. But that time we have that IOP facility where we can have the high resolution, but where the bone width, the quality of the bone, and again the magnifications and distortion of an image due to image distortion or maybe the angulation. So those are again the limitation for us when it comes to the IOP. Though radiography was there, technical areas. The slides are visible?
Yeah. You can continue, sir.
Yeah. So I was talking about the why the third dimension, because IUP we are quite aware of. Then coming to the OPG, because to overcome certain ideas of the IUP, we go to the OPG where the good overview is there. But again, the bone width, the quality of the bone, and the patient position are the we can say the crucial points to be taken care of. Sometimes.
Sorry for interrupting. Sir, slide is not there. Please share the screen.
Yeah.
Yes.
Yeah, slide is not there.
That's right. Is that okay now?
Yeah. Yes, sir.
Proceed, sir.
Yeah. So yeah, after IUPA, to come out with the certain hurdles, we jump to the OPG, where these overview is better rather than the bone quality and width was again a compromised stage. To check the quality and the width, we have switched over to the another extraoral radiographs, where the good overview was there. But when it comes to the width and the height, as far as cephalogram is concerned, we can see it only in the midline. And again, the bone quality was not as that much taken care of. But at the same time, when we look at the lateral cephalogram, we have the midline position where the overlapping is limiting our vision that what exact the pathology is there. So that's why a third dimension came across. This is what the pathological diagnosis has to be taken care of. But now when we are dealing with the patient, as far as the treatment modalities, a lot of indications and applications are there, like implantology, CAD/CAM, digital smile designing, then craniomaxillofacial surgeries, then printed medical applications and artificial intelligence. So that was the basic things of the what Roentgen shown us the path, and that was the basic foundation on which the building has built up to go for the diagnostic application to the AI implementation of the CBCT. So once the concept is clear, we are coming with our main area of the guided implantology, where the objective is remain the same, that is the prostheses are aimed at achieving the harmonious integration of the dental crown into the patient's stomatognathing system at the same time as adequate long-term rehabilitation has to be taken care of. So it is not only the replacement of the missing tooth, but the harmonious integration has to be taken care of. Because most of the time what happened, implantologist comes, implant has been placed, but after placing the crown, the patient will start saying, okay, there is some pain, discomfort, or maybe chewing is not that much proper. Implant to acha tha, but crown is not proper. So we have to look forward this as the synchronization relation of the implant and the crown prosthesis, where the role of the particular diagnosis in the third dimension comes, where the first in market in the US, we came to the where the CBCT really less, and we can always say that this is a fruitful and favorite tool where it can be visualized in one particular dimension. So these are the guys who are helpful us in diagnostic radiology, where the Worth, HM Worth, and Burkitt's are the what we are saying. So this is the basic introduction of coming to the track of what exactly CBCT was there, and then how we should enter into the market of these imaging guided implantology, where the implantology is more interested to the patient, where initially the traditional flow is placing the implant and then going for the prosthesis. But as far as the traditional flow was there, you can go ahead with the directions where you can able to imagine that where the new ideas is conceptualizing, where the particular prosthesis has been designed with the help of software. We can go ahead with the placing of the implant. That means we are designing the prosthesis as compromising with the certain steps and taking care of the better prognosis by putting the implant in the right direction. So here, stomatognathing system will be synchronizing in these ideas, where the concept will be taken care of as an imaging guided implantology. So as a part, as far as the CBCT guided implantology as compared to the freehand, there must be the both side has to be taken care of. There is one side as a patient side and another is no, being a professionalist, we are habitual to go ahead with the technology, but at the same time not to forget the patients. That is mandatory. Whatever the faster healing time, that means we cannot reduce the normal time, but lesser the trauma, better the healing. So lesser the invasive procedure, you will definitely get the faster healing time. And obviously, whatever the implant is there, where the precision is mandatory and predictability of the treatment is decided, we are going ahead with this particular as a patient point of view, and always have the provisional prosthesis. That means we have planned everything virtually, and we can do the prepare the prosthesis, and with the minor changes as a transitional denture, we can always provide to the patient. As a patient point of view, this is all win-win conditions. But when it comes to a professional time, as a being an implantologist, does treatment time is decreases? No. Guided surgery does not reduce the treatment time, but definitely the surgical time has been reduced, because no if and but, what has been executed on the virtually, that is easily taken care of. Faster healing time, definitely. Long-term success of the therapy is more important than the post-operative sequelae. No doubt you can sustain certain times the swelling will be there, the normal improved precision and accuracy is not as same in the, you can see the freehand, but as professionally it is always better, and the provisional prosthesis is given on the same time, and it is always acceptable that it is possible, and this is the truth. And last but not the least, from the professional point of view, possibility of the flapless surgery, where the less bone resorption and dental point of view, it is the most important part, because how much millimeter of the bone we are preserving and resorption post-operatively preserving, the more prognosis we can have in that particular aspect. Is the guided surgery easier? No, we need to invest the time in understanding the conventional areas, then it will be more accurate and accuracy will be there. It needs additional time for the planning rather than the treatment. That's what I'm trying to say. It is not reducing the time for the surgical way, but definitely when we are spending the more time in planning, you will get the better outcome. So taking impression, scan, importing the digital scan, conducting the virtual plan, these all are time consuming activities, but these you are not doing in the operation areas. You can have the scan, that everything you can spend the time without the patient, and all the fruitful areas can be taken out. So as most of the journals are saying accurately, computer-guided surgery is significantly more accurate, especially in the coronal and horizontal position. They have taken the angulation, cuppal error, apical error, and the results are quite fruitful professionally and the patient-wise also. Minimum invasive, avoid the elevation of the large flap, less pain, immediate implant loading, and prosthesis device prefabricated. These are the key points for our guided surgery. When we understand this more accurately, then we can go ahead with this. Now, I was saying about the precision accuracy. Are they the two same things? No. This is the accurate precisions where we have planned our implant exactly. This is not accurate, but this is precise. That means somewhere in the buccal or lingual cortical plate, we can take care of that, where no, we are too much not engaging exactly what you have planned, but this is not accurate and precise. This is somewhere accurate and not precise. That means this is accurately placed within the range of the buccal or cortical or labial or buccal areas, and this is not accurate and not precise. You are going beyond the buccal or labial cortical plate. So the precision and accuracy when we plan virtually, that can easily be executed by the guided surgery. That is what my clinical experience. Implant surgery is really a chain of process. So you need to have the precision and accuracy at each stage. So take care of this particular chain as and complete in a workplace. We need to follow the each and every process. So that is either a mixed support or either a bone type or maybe the tissue type. These are the different surgical templates are available. And you can prepare the tooth supported where the some tooth will be there, edentulous area will be there. So you need to take a support of the teeth, available teeth, and then you can go for the designing the guide and you can have the implementation. Or you have the mucosa supported surgical guide, or you have the bone supported surgical guide. We'll discuss most of the first and second areas today, because bone supported, we need to open the full flap and plan the double guided surgeries as one should placed properly on the bone, and then on that our guided particular surgical guide will be placed. So we are just discussing of the first two part, where the tooth supported will be having the greater stability because you have some adjacent teeth which will support your surgical stent in the oral cavity, whereas mucosal supported will be fully edentulous area where you need to stabilize your surgical guide with some lateral or crystal pins, and here stabilization will be the same as what you have taken the impression of the edentulous area. That's why I said it is the chain of process. We are starting from the scan to the execution of the guided implantology. Different chain processes are there. We need to thoroughly follow each step, then our result will be 100%. Because failure of implant, again a debatable topic, it is a lot of multifactorial involvement will be there. But when we are having the guided surgery, apply your traditional implantology and radiological knowledge to execute it 100%. And third is the bone supported templates, which I already said. Maybe you need to go ahead with the immediately by the maybe 2 or maybe 3 types of the guide to go ahead with that. Fixation and the lateral areas is there. And we can go ahead always, these the multiple softwares available in these areas. A lot of software I have used starting initially with the 2012, when we have the novel software, then Plan Maker, we are having the software, then we are having the different costumes also develop some software. We have the MaxFresh software, 3D rendering, then lot many more than the 50 softwares I tried and used, and I came across this is the one of the software which is giving me the incision and invasive procedure are less, which is an independent, rapid and precise way where I can plan, design, print and execute my cases maybe within a 20 minutes or maybe 1 hour, depend on the area of the edentulous involvement. So it is more interactive and simple for me. I just introduce certain software point of that also, because lot many software I use because I find it more sophisticated as far as the steps are concerned. Because first you diagnose the areas, take an impression, prepare the template, get the scan, transfer the image, scan the particular image clearly, plan it, manufacture the guide, and do the surgery. So once we go step by step in this area, we can able to understand this digital implant revolution is as simply as you are having your DICOM data, that is a digital imaging computers medical sciences, where all these images will be transferred to the virtual model and where the 3D planning is executed. So you have the one CBCT scan and you have the scan model. You just merge them and plan how that is executed. I will just go one by one. That is digital flow, scan the data, elaborate the data, and production of the whatever the conduct of the data is there. So you can acquisition of the data will be the either will be the CBCT machine, simple cameras or interval scanners are there. You can elaborate the data with the CBCT or 3-shape digital scanners, and we can data production whatever you are acquainted with the 3D printer, CAD CAM with the different mechanisms. So we have the wide open option nowadays to go ahead with this. But if we simply stick to that step by step, if one particular patient needs a guided surgery, take a simple CBCT scan. First step we are having. Then take an impression of a patient and prepare a cast on that. That is the second point that always we need for the impression and the cast. So the precise impression registration is mandatory, because this impression is nothing but your blueprint of a surgical guide, because the fitting of this particular first impression implement clearly on your surgical guide positioning. So this is the most crucial phase after taking the CBCT scan. This is the impression of the patient has been taken. On this particular impression, we are preparing a one radiographic, you can say the acrylic, transparent acrylic denture, which has been prepared with having some radiographic marker on it. Why the radiographic marker? So these are the indicator that your cast has been placed in the particular model precisely. So it will be fit precisely in the patient's oral cavity. So first CBCT we are having, we have diagnosed that, and we have taken the scan. On the scan, we have prepared this particular acrylic template, which is other way called as a radiographic template. And with this template, we are placing in the patient's oral cavity and taking one more scan. So now we are having the one scan without the radiographic template and one scan with the radiographic template. What is the importance of this? Here, try to understand that we have the one scan and we have the one more scan with the impression taken. So that between the impression taken and the scan, the area is nothing but your mucosa. So mucosal thickening has been elaborated precisely here where your abutment is going to plan. So this is second scan we have taken. Then we are merging these two scans with each other. When merging with the scan with the denture and scan without the denture, these two files are collaborated and we are executing the implant in that areas. Then we take a scan of that and we plan that both areas, design the implant and take a printout of a surgical guide on the 3D printer. So now we are having the 3D printed surgical guide with us with all the features available, where the report is explaining us which implant has to place, how it has to be placed, where it has to be placed, and we are ready with the surgical template for the surgery. So these are the simplest 8 to 9 steps has to be followed. You have the CBCT that for we don't have to invest too much. Take a scan from any CBCT scanner. You are having your own setup where you can always take the impression. You can have the acrylic model developed. You can take one more scan. Synchronizing of the scan will be possible with any software available nowadays, or this is the one which I am using from the BNB as a Italy. Then we can always have that merging with this. This particular software will give the 3D printed model ready to print. Take a printout of this model and execute your surgery. So these are the basic steps which need to follow. Once we are aware of these steps, I will go in the detail about this, because any CBCT scan is not advisable. There's a precision of the voxel and pixel is mandatory, where the CBCT machine should have good calibrated. Then data will be always in a rough data. So whatever the CBCT scan you have taken, just whatever the image size is there, just zip that file and send to our third-party software, because sometimes Sirona machines are there, DICOM images are Sirona, maybe some Dentium machines are there, maybe Planmeca machines are there, Kodak machines are there. So you just take that raw data, and that raw data has to transfer completely to the third-party images. So when we are having that images with us, we can have that medium or high resolution, and you can make it out that easily on the images. Then data, again, we are taking the one data as a CBCT image. Then second is a patient placed with the particular denture. So these stabilize with the particular bite, because it should placing in this oral cavity, you chew properly, so bite will be registered properly and stabilization of this template will be more accurate. So when this data we are having, I just say about the radiological, these particular radiographic markers. So this will help you in how you are going to synchronize your DICOM data of the plain CBCT with the denture CBCT. Once this data has been taken, we can able to appreciate these images like this is the data of the first CBCT scan and this is the data of the second CBCT scan. So you can able to make it out. There is a 2.2 millimeter of the mucosal thickening is there, and these are the radiographic markers which you are saying that these are the well adequately placed. Why you want to know these? Because this is going to define how much depth of your drills are available. So stable patient with accurate designing areas will help you in precision aligning that area, and the intraoral presentation is the proper second ring as far as our chain reaction of our guided surgery is there. Then whatever the matching of that area is there in the software, this file matching will be formulated with these particular radiographic templates. So one without the denture and one with the denture scan are superimposed with each other exactly. They are saying to accurate accuracy of that particular area. Look out this, what we are doing. This is the plan, because planning is really important for us. If it is not planned, then execution is something like this, which is needed. So very important segment. If there is a poor planning, this is what we are achieving. So this is what we are planning in the software. Now we are having the two images with us. One is CBCT and one is the denture which we have prepared. So these are synchronized with each other, and we, with the help of the implant library available with us, we can have that implant sleeves and models design. We can see the angulation, we can see the depth of the areas, width of the bone available, buccal lingual cortical areas, nearest anatomical structure. So depending on that, we or the areas which needs to be taken. After deciding this, with the 3D printing, we can have that more proper areas. So, but everything is technically sound. But when it comes around the exact patient's treatment, we need to analyze that whether patient's oral cavity opening is proper or not. And again, whatever the stent we are received, whether it is fitting same as that of our impression taken. So whatever that area is there, we need to take care of that. And at the same time, when we are drilling for the implant, what about the irrigation in that area? So these all possibilities are taken care of when we are planning correctly on the software. So these are the different dental softwares available, which makes you aware that whatever the diagnostic area scan, then lab scan, then involvement of the guide designing, that planning services is mandatory. So this is one of the part or ring of our chain which needs to synchronize really well to get our problem very clearly. So whenever you are drilling, so that time we are having that innovative sleeves where whatever the debris are coming, it will be out of these areas. So you will not able to get something stuck into the osteostomy where the good indications of your surgery outcome will be possible. So laterally, these windows are held in draining in that area, and whatever that saliva and suction possibility that we can taken care of. So these are the precise small points we need to analyze when execution of our planning is there. This is what our sweet dreams, that our buccal or labial cortical plate should be intact, so that whatever the socket is there, that will shield our implant in very nice way. So best case scenario, when there is accuracy, only if all the rings are precisely maintained. So accurate and precise, try to understand the meaning of this. It should not be neither accurate nor precise only. So without one ring, we lose all the chain. If impression is not good, guide will not fit. Scan is not better, planning is not good. Planning is gone somewhere somewhere wrong, execution will not be better. So these are the steps from diagnosis to the 3D printing area. So when these are centralized, that will be help us in deciding what exactly is this. Just take it out these figures when the patients are in the chain, when they are coming with these kind of the distorted oral cavity areas. So preoperative views of this particular patient is seen something edentulous area. When we start with the surgical postoperative areas, this is the surgical stent is designed, and this guided surgery drilling protocol is there, which guide has to be having placed properly and which drill has to be used and how the process will be going ahead. That when we plan virtually the implant, there you will get this automatic design plan also, because what is going on your head when you are executing that on the software is recording that, and when your planning is completed, you generate a report. Okay, this is the sleeve, this is the first drill, this is second drill, this much of the force, this much of the depth, and this much of the areas. So precision will be defined in a paper way what the implantologist plan actually in mind. So this is again AI supported. What you are thinking in mind, executing on the virtual screen, that will be ready-made available as execution of the plan. So we plan it. We now have the diagnostic patient's oral cavity opening. Now try the stent in the oral cavity. Check it out whether it's fitting properly. And then with the lateral or anchor pin, just fix it in the oral cavity. So this is what your exact location of your stent, which is there accurately, a replica of your first impression you have taken. This is similar to that only, where your central lateral areas, this one execution point. So this must be the all-on-4 case, where the 1, 2, 3, 4 implant has been planned. So now we are having the surgical plan. Stent has been tried in the oral cavity, and now it is a fix. Now I can say that I remember when this has been fixed, the school days, where we need to have that draw a round or map of India. We have that stencil. A blind man also can easily that stencil with the round or maybe with something called as a map of the India. Same way. Now you have everything, spend the time in the planning, how it will be executed, prognosis, everything we have planned. And now actually the surgery again in a blind person can be done. This is no more a blind surgery now. You don't have to go anywhere in the angulation. Everything has been planned on this particular stent on the virtually, and you can execute in the patient's oral cavity. Start the surgery as the protocol is given. 1.5 millimeter drill, then extend that by 2.5 millimeter drill. Then length and width as per the guidelines of the planning is given. They are executed. Site is ready for the implant placement. Then place the implant in the patient that area. All the 4 implant has been placed and remove the stent. Have you seen any flap in this area? I cannot see that. Have you seen anything like bleeding or swelling in this area? No bleeding, bloody areas, nothing. It is simply 4 implant has been placed nicely. Simple blood points are there, and we can execute that much of the surgery. The time which I have taken to explain that is more time than whatever the actual surgical time which we have invested. So this is something, prosthesis has already been prepared. So we're just taking here and there slight modification as a transient denture, and we are delivering that. So look at this particular case, all-on-4, the case which I have done when I was doing my guided surgical training also. So you can check it out the date also. It is the 20th of the December in 2013. So more than 12 years now, we can say. Diagnosis is there, an implant order, execution of the planning, guide has been taken, stabilization of the guide, then this is the placement of the implant. You can make it out the photographs also. See, this is the 2:22 almost in the afternoon. We have taken the sterilization of that particular, and 2:45. So we can able to finish that within the 20 minutes, this particular case. 4 implant has been placed nicely and prosthesis has been given. So this was the case available in 2013 when I have done some routine of the all-on-4 and all-on-6 cases with the Nobel guide, where I used to get the guide from the Switzerland, or these are the companies at the 45,000 per costing. But that time I was little more passionate about these. So we can able to work out these cases since 2013. And I was not never believe in opening that and seeing the bone as the oral surgeons or periodontists are looking forward. But I prefer the minimal invasive that time cases. So this was the result. So this is what you get the exact location of the implant. This is the good cases what you can observe. These are my own cases which I have seen. These are the cases where your healing screws are given nicely after placement of the implant. Then these are the areas where you can have the cover screw, remove the cover screw. These are my own cases in my own clinic where I can able to make it out. So when these kind of the cases comes, when the chain is proper, you can execute nicely. Outcome will be like this. Just because the BNB softwares are providing these images, so I'm just showing that. So these are the areas where we can work out. This is a surgical stent. Guided surgical stent is not only in the edentulous areas, but pterygoid implants also will have the surgical guide. Then we have the Luxa grids also available, where the custom-made implants are prepared by taking the bilocular areas, and we can have that particular pterygoid implants. We tried some severely atrophic areas where 2-3 pterygoid cases are really successfully done, because that is completely too much diagnostic area, blind process. But pterygoid implants we have nicely done. These are having the separate kits and different length of available with that. We can have the pterygoid implant component also with that, with the different drills. So not only the routine surgery, but the pterygoid implants, zygomatic implants, and custom-made implant. These are the possibilities where we can go ahead with this. But as a note down for the young dentist, knowledge is knowing that a tomato is a fruit, and wisdom is not putting it in your food salad. So surgical experience needs to be taken care as a conventional experience, and implement that is digitally is a two different things. So get yourself knowledgeable with the basic things. It is not that you advise the guide from any center and it will do the guided surgery. No, that will be your responsibility to know the true and false of the cases. So the knowledge is something, knowing the things. So this is what the clinical picture of the short presentation. Thank you so much, Dr. Abhay and team, for giving me the opportunity and listening the things very thoroughly. Those who are interested, they can join the fellowship with London Academy, which is available online courses also. So this is what those wanting to grab the knowledge in more directions. Thank you so much. Thank you so much. We can open the session for the question answers also.
Yes, sir. Thanks a lot. It was a wonderful session, sir, and having an interaction and knowledge of some of the new concepts for me also, and which is totally very valuable for us. Probably some of are new in this. So are there any questions, Dr. Sudhir? Dr. Sudhir, please take up the questions.
Yes, sir. I request all of you, all the attendees, 5 questions can be asked here, or we will ask Mahendra sir, Dr. Mahendra sir. Please go ahead with the questions. You can put up your questions in the chat box, or you can put up the questions in the WhatsApp group also, or switch on your audio and switch on your video as per your comfort, and you can interact with Dr. Mahendra sir, respected mentor today. Anyone wants to ask the question?
So I will take it that everything has been understood. No questions with that.
Yeah. Sure.
Dr. Tejavati Nagraj, she is thankful to you, sir, and the organizing committee for such a good webinar. She has texted here.
Yeah. Thank you, doctor.
There is some question somebody's asked. Yeah. So if there are no questions.
Yeah, I think Dr. Manisha is asking something.
Yeah, there is a question from Dr. Manisha Lakhampal. Of the implant, lot of confusion is there about it. What exactly she wanted to ask, I don't know.
The question is how to take the angulation.
Yeah, so regarding the angulation.
Hello.
Yes, sir. Yeah, regarding the angulation, you have the CBCT scan and of course the available bone quality, where the bone areas are taken care of. That areas
going
to define you the clearly.
WhatsApp pe dal dijiye.
And as far as implant placement is there, always try to make it vertically placed as 90 degrees, because load of distribution is always in that direction, because simple mechanics has to be taken care of. But when it comes to the angulated implant, that 17 to 34 degrees angulation is mandatory as far as there is idea. So when the concept of the implant placement is the respecting the most nearest anatomical structure and that angulations will be taken care of by the availability of the buccal and lingual cortical plate areas. So more abundant bone is there, because nowadays after placing the implant, we do have the abutment with the different angles. So load will be distributed as the mechanical way. So as far as angulation is there, stick to the available bone qualities where you are going to place the implant. And as far as vertically load distribution is mandatory, because it is against the mechanical force, and up to the 17 to 34 degrees angulation can be taken care as an accepted in this area.
Okay, sir. Thank you.
If the query is clear, it's okay, or otherwise she can ask Dr. Manisha.
Dr. Manisha, if you are satisfied with your query, please let us know. And Dr. Imran Sunibora, he is asking, sir, question for you. For a person who is zero for implant, how to proceed? First, we have to learn what, sir? Like he wants to know, sir, how to start with scratch for implant.
May I know who is Dr. Imran? Is it the UG, PG?
Sir, he is from Ahmedabad, private practitioner.
Okay, private practitioner. Okay. So, doctor, if you are labeling yourself as a doctor, there is nothing like a zero to the implant, because you know the bone structure. So, you are already achieved the 50% part. When we know the basic anatomy, that is 50% part is already been achieved. It is not the execution of the implant, how you should start. So, my suggestion will be, whenever the patient comes to you with the CBCT, just go for the 3D printed model of that particular patient. The mandibular single tooth is also missing now. So if you want to place in that area, just go for the simple 3D printed image of the mandible. You will have the mandible in your hand, and then you can have that implant kit with the dummy models, dummy drills. So you take that drills and directly do the drilling in that particular 3D model. That will be your, you can say, the Rangit Talim for your next patient. So the same patient you can do with the execution of the putting the actual drills, and you can go ahead with these. It is the simplest part. You are already 60% anatomy is there. So it's just the mechanical growth we have to add as the 40%. Because being a dentist, we are already artists and scientists also. So we can go ahead with this, no problem.
Thank you, sir. There is a appreciation from senior faculty, Dr. Smita Chopre, ma'am.
Thank you, doctor.
Thankful to you. Then question is there, sir, from Dr. Anjali. Which textbooks we can refer for implantology?
Yeah, a lot many. Starting from where you need to clear up your concepts. Just stick to the certain overview of routinely going for the clinical practice, where the filling, removal, and replacement is the only agenda with this. But when you want to thoroughly start with, I will suggest that just open your first anatomy book. As a, you can have that, maybe the Chatterjee is there, or maybe your what we are routinely using your for the dissections area of the anatomy is there. Open up that book, try to understand and analyze the bone quality. That is the first thing what we have done in the first year and second year. For that time we don't have the vision for that, what we are exactly looking for. So I will suggest you go and revise yourself with the Cunningham's and Chatterjee or Banerjee's books, and then physiology book. Understand the physiology, understand the thorough anatomy first, and then radiology will explore you to go with the implantology. So that is what I have done after my PG also. Knowing the, because we know that maxillary sinus is there. It is a hollow cavity, but we never appreciate it is at the pyramid. When it appreciated to be pyramid, we look for the 5 sides. So 5 areas of the pyramid we look forward, where the floor is there, where the base is there, which are the walls is there. That anatomy, once we understand for each and every area, then it is quite possible to go ahead with the areas. So I will suggest that basic textbook of physiology anatomy, followed with the implantology. That Karl Marx book is always preferred, because he is the father of the implantology. So he will explain you, and go ahead with the short courses. Whoever you are comfortable with your colleagues, go with the short courses. Don't go with the hi-fi names and hi-fi courses. That will go out of our head. So just connect with our areas where, if you know a city nearby, somebody is taking the small courses on implantology, go and join that. Your basic concept is clear. Then go for again with the bigger name of the concepts, and then go for the some abroad fellowship that can be possible. So this is the way what any student should learn.
Yes, sir. Completely agree with you. And we will share the textbook of the Karl Marx in the WhatsApp group on your behalf. I will do it, sir.
Yeah, that is the next question. I'll go for the next question.
Dr. Shweta Gangotri, she's asking for immediate implants. Very thin bone is present buccally and palatally, then should we consider it during the length measurement?
Of course, doctor. Of course, because how much socket you have saved. If there is a no buccal and labial cortical plate, it is very difficult to go ahead with that. Because again, your knowledge of the ridge split or ridge augmentation comes in the picture. How much you can split the ridge and go ahead with that. That will be depend on the patient, whether buccal or parallel area. Then again, the options are available, either all and 4, all and 6, zygoma area or pterygoid area. So thin bone is not the limitation, but taking into consideration thin bone is a limitation, is a limit. So either you can have a lot of possibilities of going ahead either with the different bone secured areas or custom made implant against the issues to be taken care of. Nowadays I'm planning with the custom made implants. They are custom made, they can feasible very well, they have the bone plate prepared nicely face to face, and I get the result implant with attached abutments. I just need to fix the screws after maybe 10 days or 15 days. So this is again when the thin ridge is there, these options are always available, doctor.
Thank you, sir. Everyone has thanked you for your guidance, including Dr. Anjali, Dr. Shweta, Dr. Imran, and Dr. Manisha.
Yeah, thank you so much.
Sorted out. Thank you. Thanks a lot.
Anything else will come to you personally, sir?
Anytime come to university, it's open.
Thanks a lot,
we don't
sir.
Know, sir.
Thanks.
You will be available or not?
No.
Yeah,
sir is always there. He has given a time from his busy schedule on a very short notice. So I'm very thankful to him. He's my friend. I can ask him to come at any time. That is another thing. But this is what. Thank you very much, Dr. Mahendra Patait, sir.
Thank you so much.
Yeah. Should we go for a next this thing? Yeah. I think our next speaker is ready. Dr. Sudhir, I think you take a...
Before this, I would like to make an announcement here. Today's host, Dr. Abhay Kulkarni, sir, who is organizing committee for this CDE program project. This is 3.0, that is third webinar. We have completed 2 before this, and we are going to have this project for 2025 to 2029, which is organized by Dr. Abhay Kulkarni, sir, and
MIDSR. And
Dr. Hange, sir, who is the principal, is supportive. And all the MSDC representatives, and today's representative is Dr. Pratik, sir. So I would like to announce here, Dr. Abhay Kulkarni, sir, has been awarded for national award from the IDA, that is Charaka Award, and today it is going to be held in Geo Convention Center, Bandra. So he is awarded for excellence in clinical dentistry for oral medicine and radiology. And today is 138th radiology day. So it is so nice to know that, sir. Congratulations from all of us to you.
Thank you. Thank you.
All the senior faculty.
Okay. Thank you.
Let's move on to our second webinar.
Dr. Venkatesh Hange, sir, from MIDSR. Yeah, you introduce. Dr. Sudhir, you introduce.
You are going to do, you do, sir.
No, you introduce. Okay. You introduce.
So let's welcome our today's second mentor, Dr. Venkatesh Hange. Dr. Venkatesh Balaji Hange, sir, is an oral and maxillofacial surgeon and reader at MIDSR Dental College, Latur. With clinical and research expertise scanning maxillofacial trauma, implantology, and head and neck oncology care in the institute. Let me introduce in short, welcoming Dr. Venkatesh Balaji Hange, oral and maxillofacial surgeon, reader. He is an innovator of the patented VBH Trinity mini plate and lead author of the Immediate Implant Placement Success Index with 25 plus publications and editorial contributions advancing maxillofacial implantology. So he's here to teach us complex implantology cases and radiographic strategies for implantology. So let's welcome Dr. Venkat, sir. Sir, please go ahead with the presentation.
Okay. First of all, thank you, everyone. for giving me the opportunity to present from my perspective, that is oral surgeon perspective, regarding the radiographic strategies in complex implantology cases. I will be just sharing the presentation. So coming to the topic of my presentation, this is complex implantology cases and radiographic strategies, integration of pterygoid, zygomatic, and nasalis implant in successful dental implant therapy. So, as I introduced earlier by Sir, so I will be discussing about the complex implantology cases. Hmm. So, in complex implantology cases are the cases in which there is deficient the posterior maxilla, or there is some defect in the maxillary area or mandibular area, in which the conventional implants or conventional all-on-4 or all-on-6 can be cannot be possible. So in that cases, we take a remote anchorage. So remote anchorage can be from either from zygomatic area, zygomatic complex area, either from the pterygoid or from the nasal area. So these are remote anchorage, which we can take the help of it and do the successful implant therapy. Hmm. So in this therapy, so the radiographic plays an important crucial role, because these remote anchorage areas are the somewhat complex anatomy, and it requires precise planning to get a successful implant placement. So in that cases, CBCT is of great help, and with the digital planning workflows, we can maximize the success of these implants. So the in general, the success rate of zygomatic implant is around 96%, as well as the success of the pterygoid and nasal is implant are more than 95% or more than 90% for a follow-up period of 5 years. Hmm. So, because of this, these are the cases where we can, these are implants we can perform in this complex cases. So, the main challenge of the conventional implant therapy is the severe maxillary atrophy. Sometimes, in cases whereas patient has undergone extraction very long period of time, around 5 to 7 years back, patient has extracted tooth and has not been replaced since. In such cases, the scenario comes in such way that the maxillary or mandibular alveolar bone undergoes continuous resorption at the rate of 1 to 1.5 mm per year. So over the span of 5 to 7 years or 10 years, that becomes a great number. Hmm? So in such cases, there is deficient maxilla or mandible, and then the conventional implantology becomes absolute. So for these cases, there was in 1990s or in the early 1980s, there was discovery of, first of all, pterygoid implants, zygomatic implants, and later on nasalis implants were done to provide fixed maxillary rehabilitation to such patient in which, because of their neglect, the bone is lost and cannot be treated by conventional methods. These advanced techniques leverage the dense cortical of the pterygoid plate, zygomatic arches, and paranasal structures. So these areas are which areas which have multi-corticated uh, areas. That means there are not only buccal and palatal or buccal and lingual cortical plates, there are also other cortical plates. In such cases, in the nasal area, there is buccal and palatal cortical plate along with the nasal floor, or sometimes in the transnasal there is also lateral nasal wall. Hmm? And in cases of pterygoid, it is a junction between the maxillary tuberosity along with the medial and lateral pterygoid plate. Hmm? And in cases of zygoma, it is zygomatic complex area with multicorticated appearance. So in such cases, if we take an anchorage and place an implant, it can give us an immediate stability and function without any need of grafting or any need of any continuous or long-standing procedures such as bone grafting, along with the follow-ups and the delayed implant placement and delayed prosthesis. So such things can be avoided. So in my today's seminar, we will focus more on the immediate loading, immediate extraction, along with the this nasalis, pterygoid, and zygomatic implants. So, for a successful complex implantology cases, there is a need of accurate three-dimensional radiographic assessment, and meticulous pre-operative planning, because this technique involves navigation through cortical anatomical structure of the maxillary sinus, orbital floor, infratemporal fossa, nasal cavity, and neurovascular bundles. So, these are all the areas surrounding the complex or a vital structure. Hmm. So if we are not prepared with the proper planning, we can fail and we can go into complications. So radiographic imaging serves as a multiple essential functions: anatomical mapping, virtual surgical planning, intraoperative guidance, post-operative verifications. So these are all planning gives us the final predictive success. The presentation of this seminar systematically examines the radiographic strategies that enables successful outcome in complex implantology, integrating evidence from the recent systematic reviews, clinical trial, and accuracy studies. So coming to our topic, so the pterygoid implant. So the pterygoid implant, as we know, is situated in a molar posterior molar area near a second molar or third molar area. Hmm? Anatomical considerations. So this is the pterygoid process denoted by the arrow. It is a site for anchorage of the pterygoid dental implant. So the anatomical foundation and radiographic landmarks. So pterygoid implant derived the anchorage from the engagement with the pterygomaxillary junction. As we discussed earlier, the pterygomaxillary junction is the multicorticated bony complex formed by the maxillary tuberosity pyramidal process of palatine bone and pterygoid process of sphenoid bone. So why the pterygoid area is considered for the implant placement? Because it is multicorticated area, as well as it has a higher density as compared to the adjacent landmarks. So why there is a higher density? Because in grayscale density, if we measure, it is around 692 plus or minus 85.5 grayscale density, which is 139 140% more than the tuberosity area. So it becomes an ideal site for implant anchorage. The superior bone quality, characterized by dense cortical bone engagement, provides the primary stability. So, and how, when we start with the pterygoid implant, so how will we palpate? How will we come to know that our implant is placed properly? So it can be reassessed by hamular technique. So there is a hamular notch there, and in the posterior, the third molar area. So during implant placement, we continuously place a finger and palpate the hamular notch, hmm, to get a accurate judgment regarding the implant placement. So the pterygoid implants has a various radiographic parameters, which includes vertical angulation and horizontal angulation. So the pterygoid implant placement is a we have to place in a angulation. Why? Because the plate is situated at an angle, so we have to engage that angle. So there are two angulation. First is vertical and second one is horizontal. So the first vertical angulation is roughly around 45 degrees. The range is between 37 to 62 degrees to the FH plane, but it is normally we can consider at a 45-degree angulation. And the horizontal safe angle is around 20 degree buccal and 20 degree palatal, minus 20.7 degree palatal. That means we have to approach the pterygoid plate from somewhat at an angle of 45 degree from the buccal area to reach the pterygoid plate. And the CVCT voxel size is around less than 0.2 mm to the anterior nasal spine to pterygoid plate. So in this image, you can see the placement of right pterygoid implant, placement showing variable vertical and horizontal angulation. In the vertical, it is approximately 45 degree, and in cases of buccal, it is around the 20 degree to reach the pterygoid plate. So the range of this vertical angulation ensures engagement with full height of pterygomaxillary junction. So if we go below 37 degrees Celsius, we will not engage at the full length of pterygomaxillary junction. If we go over the 45 degree, 60 degree angulation, then we might damage the adjacent neurovascular bundle. So avoiding the perforation into the infratemporal fossa, because there is infratemporal fossa just adjacent to it, and it has a neurovascular bundle. So we might get inadequate bone engagement, as well as complicate the procedure by going into the infratemporal fossa. The horizontal angulation, as we discussed, this parameter defines the three-dimensional corridor within which implant can be safely placed. So, if we forget the angulation and we go beyond our recommended angulation, there might be engagement into the vital structure, which complicates the implant placement. So post-operative CBCT verification demonstrate mean vertical angulation around 54.25 to plus or minus 8.56 angulation, confirming surgical accuracy when this radiographic guidelines to be followed. So the radiographic success criteria and outcomes. As we seen the how pterygoid implant anatomy is there and how it is placed and what should be the angulation vertically, horizontally. So in gross we can know that uh, radiographics measurement and radiographic confirmation through immediate post-operative CBCT gives us a proper implant positioning within the pterygomaxillary junction, and it is essential to get pre and post-operative CBCT in cases of these pterygoid implants. The success criteria defined in recent prospective studies include absence of peri-implant radiolucency. So, how we measure that our pterygoid implant is placed successfully or not? So, it is based upon the follow-up period, the absence of peri-implant radiolucency, marginal bone loss less than 1.5 mm during first year, and maintain bone to implant contact at the pterygoid anchorage confirms that you have placed successfully implant not only clinically as well as radiographically. So the clinical outcome studies success rate ranging from 88.57 to 95% at a 1 year follow-up, and place in a D2 or density demonstrates superior outcome as compared to D3. So the D1 is most dense bones, whereas D4 is least dense bone. So D1 bone is mostly in a anterior mandible. D2 is seen in the posterior mandible as well as anterior maxilla, and D3 and D4 bone are most probably seen in the posterior maxilla, maxillary molar area, first, second molar area, up till the maxillary tuberosity. Whereas in, as we know that in pterygoid implant area, there is a multicorticated border. So the becomes bone quality becomes D2 to D1 comparable. So in that area, if you place implant, the success is more. And the when comes to the planning of implant placement, the usual range of pterygoid implant placement ranges between 15 mm to 22 mm. Usually 18 or 20 mm implant is sufficient to get anchorage into the pterygoid area. pterygomaxillary junction area, and diameter usually recommended is around 3.5 diameter. Okay, because these implant are thin and long implant. And the torque achieved is usually around the 50-60 newtons centimeters of torque. So you can go with immediate loading. As the torque is more, you can proceed with immediate loading. The radiographic monitoring protocols recommended is around the radiographs at a 6, 12 or 24 months post loading to evaluate the marginal bone levels. Coming to the after pterygoid implant, the most commonly used anchorage area is zygomatic area. So zygomatic implants are next step. So zygomatic implant represent most radiographically complex procedure. So even during the learning period, so I learned the zygomatic implant at later stage when I am confident with my all-on 4, all-on 6 or a regular implant placement. Then I proceed with the pterygoid. Then I proceed with the zygomatic implant because it demands more of a proficiency in your surgical hand, as well as it demands more works with your anatomy, radiographic assessment with the CBCT, and the skill you required to get the zygomatic implant placement. So the implant most radiographically complex procedure, an implant requiring comprehensive three-dimensional visualization of multiple anatomical regions, including maxillary sinus, zygomatic bone, orbital floor, infratemporal fossa, and infraorbital neurovascular structure. Because if you are not well versed with the anatomy and your physiology, your basic things, you will end up in the complications. We have seen some cases that zygomatic implant enter into the orbital floor. Sometimes it pierce through the zygomatic bone and enter into the soft tissue, which later undergoes fistula formation on the skin, or it might end up in a failure because of the improper placement, yeah, even after 1 or 2 months or after 1 year follow-up period. So these are complications, and so to avoid that complication, we will start with the radiographic findings, anatomical landmarks to get the successful zygomatic implant placement. So, while considering the zygomatic implant placement, it is placed via two techniques, that is extrasinus technique and intrasinus technique. And it can be approached via buccal technique or palatal. So the extrasinus technique is buccal approach. That means we drill around the alveolar bone and outer surface of the maxilla and till enter into the zygomatic area. So, and in the intrasinus, it passes through the alveolar bone, alveolar socket, and the window is created to expose the sinus area on buccal side, and we will, as we goes drilling, we will see how there is movement of drill into the this sinus area and passes till the zygomatic arch, so that we have to visually by open method we have to visually recognize in cases of palatal technique. Okay, and so there are, as we know, that is maxillary sinus undergoes continuous pneumatization. There are various stages of pneumatization we can encounter patient. So in this image, you can see the Karl Misch has a classified subantral region into the posterior maxilla into capacity, so four categories. So SA1, SA2, SA3, and SA4. So in SA1, you can see that alveolar bone height is adequate. Patient has recently undergone extraction. There is no resorption. Clinically significant resorption is evident. In that, maxillary sinus is in normal position. It has not undergone severe pneumatization, and the height is around more than 12 mm. So it is ideal for your conventional implant placement. You will not need any zygomatic implant in these cases. Okay, so the next case is SA2. In SA2, the alveolar bone height is reduced because sinus has the patient has extracted the tooth within a 6 month or 1 year or more than 1 year, and because of that there is slight bone loss. Around 1 to 2 mm of bone loss is there, and because of that the length is 10 to 12 mm alveolar bone height. So in such cases, you can manage this case with the help of your transnasal pterygoid implants, and do sinus lifting to rehabilitate molar area, indirect or direct. And in next case, the SA3 and SA4. In SA3 and SA4, there is severe pneumatization. The alveolar residual alveolar ridge height is less. In SA3, it is 5 to 10 mm, and in SA4, it is less than 5 mm. In such cases, we cannot rehabilitate, we cannot place implant in the maxillary molar area. So, how we can rehabilitate such patient is with the your zygomatic implant. So, SA3 and SA4 conditions are managed with the zygomatic implant, and in some cases you can manage the SA2 with zygomatic implant, but it is mostly indicated for SA3 and 4 cases. So, in by the percentage, we can see that the medium, that is 52.3% cases has a medium sinus concavity, and only 34.595% has a small, and large concavity is seen in 7.35. So anterior sinus wall concavity influence the decision of intra and extra sinus. If the concavity is more, you have to go with this palatal technique or intrasinus technique. If the concavity is less obvious, then you can go with the extra sinus technique. So these are two the conditions which defines what technique should be used, whether we use intrasinus technique or extra sinus technique. The anterior sinus wall concavity influence the decision between intra and extra sinus placement. So coming to the next part, I will explain on this image. This is my case. In this section, CVCT section, you can see the both zygomatic, the arches. Okay. So while considering the implant placement, we have to assume the shape, concavity, as well as the thickness of the zygomatic bone available, and based upon that, we will measure the implant length. So first of all, on right side, you can see the thickness is around 18.2. That means the normal range is around 15. The patient has 18.2 mm. That means patient has a prominent cheekbones. Okay. And you can see there is in yes almost like a SA4 case in which the residual alveolar bone height is around 1 to 2 mm only on both sides. In this image you can appreciate. So in such cases there is no other options available conventionally, so we have to go for the bilateral zygomatic implants. And on the left side, similarly 18.4 mm thickness of bone, the zygomatic bone is there, and in the concavity is less concave, so we can try with your extra sinus technique. In cases of right side, we have to go with intrasinus only. So the radiographic analysis levels that posterior superior region and point A3 and center of the zygoma, point B, refers to the largest bone to implant contact. It is around 15.92 to plus or minus 4.16 mm, and 12.02 to 3.62 mm respectively. The minimum zygomatic thickness required for safe implant placement is 3.75 diameter, and implant is 5.75 mm. So insufficient thickness if is there. So suppose in this case, if there is thickness of zygomatic bone is insufficient, there might be piercing of this zygomatic bone in this area, and it might go outside. So if it goes outside and if it is with the contact with the soft tissue, there might be chances of infection if not properly maintained. So the radiographic planning parameters for the and implant trajectory. The optimal zygomatic implant trajectory is defined by specific angular and linear measurement derived from CBCT analysis. The relative to the vertical axis, typically axis range between 43.2 to 60-degree angulation. So it is insertion angulation is around 43.2 to 60 degree with mean values around 45 degree reported in large vertical virtual planning studies. The specific angle is determined by relationship between the desired emergence position at the alveolar crest, ideally at the first molar region, and optimal apical anchorage point in the zygomatic body. So the recommended the position from the implant placement is around first molar area, but there are variations in zygomatic implant placement such as quad zygoma or hexazygoma. That means on same side we can place two zygomas or three zygomas. Hmm? Similarly, with all due with the virtual surgical planning and surgical guide, because if you have to place a four zygomas in a arch, you have to be very much precise. You can place with your free hand one zygoma, but if you have to place a two or three zygomas on same side, you have to only and only go with the surgical guide. Hmm? Because the precision is required in cases of quad and hexazygoma. And if we have to place a quad zygoma, we cannot place two implants from the same region. So there are variations such as we can place the zygomatic implant from the lateral incisor or canine area, then from the premolar area, second premolar area, and from molar area. So in this way, the three areas uh, are given to engage the zygomatic body from the zygomatic implant placement. So this is my case. In this, I have done a basal implant, full mouth basal implant with immediate extraction and implant placement. In this image, you can see there is right zygoma placed from the premolar region, whereas the left zygomatic implant is placed from the lateral to the lateral incisor and canine region. So in this way, I have managed this case, and as the basal implantology, it is another branch of your implant dentistry in which the bone is engaged in a basal bone. In mandible, it is the lower lower ridge of the mandible, and in maxilla, it is around the parallel to the nasal floor. So in this image OPG, you can appreciate that all the implants in the maxilla are in line with the parallel to the nasal floor. And the zygomatic implant is in the right side, I have placed around 45 mm. In left side, I have placed around 52 mm, all with the diameter of 4.5 mm. So if you have to engage the zygoma, you have to minimum diameter of the implant engagement is 4.5 mm. And the range from the zygomatic implant starts from 35 mm to up to the 60 mm. Okay. And next is the implant length selection. It is guided by radiographic measurement from the plan emergence point, optimal anchorage zone. And the thing between the freehand zygoma placement and guided zygoma placement. The difference between freehand zygoma placement and guided placement is that you have to, when you have place implant with the freehand, you have to get multiple sizes of zygomatic implant. It is hollow from inside. change in the drill direction will end up somewhere else. Okay, so you have to so once you get the surgical guide, once you place a surgical guide into the cavity and drill it, then you need only one implant to get a successful implant placement. But in cases of freehand, you have to have an arsenal of multiple zygomatic implant to get a successful implant placement, because the anatomy of the zygomatic body is such complex that if you miss by 1 mm, you will end up entirely elsewhere. And the judgment of the implant placement, you will not get a torque. If you not get a torque, you will not place a implant. Okay, so this is the major difference between, and in case of freehand, you will require much experience than that of in guided surgery, because everything is decided by um, devising a surgical guide pre-operatively, that you will get less complications. So the most frequently used length is 40 mm, though the lengths ranging from 35 to 52.5. Recently, they have introduced a size of 55, 57.5, 60 mm. So it differs case to case. The CBCT-based planning software allows the precise measurement of the required implant length while accounting for the oblique trajectory through the maxillary sinus. The goal is to achieve apical anchorage of at least 8 to 10 mm. So if the length of the entire bone available is around 15 mm or 18 mm, 20 mm, then you have to at least engage the 8 to 10 mm to get a sufficient anchorage. Proximity to critical structure. So must be meticulously evaluated radiographically. The orbital floor represents the superior limit of SAPE implant. So requiring maintenance of at least 2 to 3 mm safety margins. The infraorbital nerve exit point, clearly visible on CBCT, dictates medial wall of implant window, and the posterior angulation exceeding 50.6 degree increases risk of orbital floor perforation. Okay. So just with my previous slide, I will explain OPG, this thing. So in this, you can see this is the triangular area body of the zygoma. Okay, on left side. So how will it decide we will not end up into the orbital floor or the orbital foramen? So while after exposing the this zygomatic area, you have to, first thing is that you have to visualize the orbital floor from intraoral perspective, as well as the locate the infraorbital foramen, infraorbital nerve, and posteriorly you have to extend till the outer border of the zygomatic body. So after visualizing, after exposing this three structure sufficiently, you have to follow the path. So 5 mm from the lateral margin is the safest position where you can start your drill. So after deciding your safest position, you will start drilling. So first of all, you have to create a suitable position if you go with the extra sinus technique. So these both implant are placed with the extra sinus technique. Okay. So the next thing is, so after exposure, you have to prepare a alveolar crest site, and it is prepared with the help of diamond burrs. Long diamond drills are there, 35 mm length maximum is there, and this will prepare the erode the buccal surface in such a way that it will create a path of this conventional this basal zygomatic implant placement in such a way that it will not hamper with the occlusion of the patient. It will emerge on the occlusal side or palatal side, but not on the buccal side. So after creating the alveolar crest, preparing the alveolar crest, next step is directing the drill into the osteotomy area. So how it is done? So there are the tapering drills are available, which will first of all you have to mark the area and make a entry. After making entry, you have to go from the alveolar crest osteotomy, where you have remove the buccal bone and create a path. And by following the path, you will drill. And after drilling, there are 80 or 90 drills are available, which will enter into the hollow zygomatic body and engage the lateral most portion where you want your implant place. So after drilling that area, after you will feel a ditch about after drilling about 8 to 10 you will fill the ditch. And after filling a ditch, you have to retract the this drill and the place the zygomatic implant. And if you go with the proper angulation, then you will get a high torque resistance to implant placement. So with the help of hand driver or the implant driver, if you place the implant, then we get a resistance. The torque is nothing but resistance offered by a bone to the implant placement. Okay, so the high torque is achieved, you have successfully placed implant. Okay. So as we discussed earlier, these are all the same things. So there is a study, comparative study of 72 zygomatic implants showed superior accuracy with CBCT guidance. So there was one study in which they take a multi-slice CT scan as well as CBCT scan in the same patient and check the efficiency. They have placed a zygomatic implant on one side with the help of CBCT and another side with the help of multi-slice CT. So multi-slice CT was precursor of the CBCT. Before CBCT, there was a multi-slice CT available, but as the radiation of multi-slice CT is 10 to 12 times higher than the CBCT, it was later on becomes a absolute. And then the CBCT came till now, it is a gold standard. Okay. So this study shows that if you go with the CBCT, there is preferring a preferred imaging modality with higher accuracy, precision, and lower complication risk, as there are less deviation. So there is higher risk of success. So coming to the next implant, that is transnasal and nasal implant. Okay. So these also comes under the remote anchorage system. Okay. So in this implant placement using Wunderlim's transnasal approach. So Wunderlim's transnasal approach suggests that implant should be placed from your first premolar, second premolar area and engage into the lateral nasal wall. So this is the lateral nasal wall and combining with the nasal floor. So you have to engage the implant in this area. So it is called as transnasal implant. Okay. And when it only this it is placed from the anterior aspect and engaging the nasal floor, then it is called as nasal implant. So there is difference between this. So in this image, you can see this implant is at the piercing the nasal floor. So this implant is piercing the nasal floor, so it becomes a nasal implant. It is placed from the socket of the second left first molar, first incisor area. So it is engaging the nasal floor, and it is called a nasal implant. The second one is pictorial presentation of the implant placement using regular pterygoid approach. The C, pictorial presentation of implant placement using distalized pterygoid approach. So this includes this pterygoid as well as transnasal approach. And in E image, you can see implant placement using regular crestal technique. That means the crest should be engaged or pierce the this cortical bone. The nasal, the nasalis or transnasal implants are now new option for implant dentistry used for patient with severe anterior maxillary bone loss. So if there is severe anterior maxillary bone loss, the regular implants cannot be placed. In such cases, you can go with nasalis implant. They helps to provide an anterior support for dental prosthesis when bone height and width are insufficient for conventional implants. The implant pathways, the implant passes through the nasal fossa and it engages the subnasal alveolar bone, lateral paranasal cortical bone, and prelacrimal bone near the inferior turbinate. So this is the image. So these are in red and green. These are transnasal implant, whereas this is the images shown in the yellow are nasal implant. So as it is engaging the multiple cortical areas, increases the implant stability even in cases of severe bone atrophy. The radiographic planning need, because it is of complex anatomy, specific radiographic guidelines are required. So this point at the junction of lateral the wall of nose and nasal floor is called as Z point. So in transnasal implant, this must be engaged near the inferior turbinate region. The function, the implant apex engages the dense cortical bone in this area, provide strong apical anchorage, and it is evaluated using sagittal CBCT sections. The apical engagement length ideally measures 3 to 5 mm of optimal biomechanical stability. So it should be engaged around the 3 to 5 mm of cortical bone, bicortical bone. So how we can go with this transnasal implant placement with the help of CBCT and CBCT planning. You have to identify the landmarks such as lacrimal canal, first and most crucial structure, Z point, prelacrimal engagement point, and coronal plane. You have to go for locate the inferior concha, and axial plane. You have to just above the inferior concha. So coming to the anatomy, so the Simmons classified the coronal CVCT sections by evaluating the position of the nasolacrimal canal relative to the maxillary wall. So type 1 is most lateral, type 2 is intermediate, type 3 is most medial. So type 2 and type 3 are provided sufficient medial space for implant placement. So I will explain that. So this is the separate coronal section as per the Simmons classification, and its relation with the anterior maxillary wall and border of nasolacrimal duct. So in the first, the rounded part is the nasolacrimal duct. So in type 1, it is close to the nasolacrimal duct. So there is chances that during transnasal implant placement, you might damage the nasolacrimal duct. So but in cases of type 2 and type 3, there is sufficient bone. In type 2, there is around 5 to 6 mm of bone between this nasolacrimal duct and this anterior maxillary wall of sinus is present. So you can sufficiently engage the transnasal implant. And in type 3, the nasolacrimal duct is far behind the anterior maxillary wall of sinus. So there is most ideal for implant placement. But the main limitation of this transnasal implant is that there is no the till now the review of literature has less follow-up period, shorter follow-up period of this implant as compared to the zygomatic pterygoid, which has a longer uh, follow-up period around 5 years, 10 years. But the transnasal technique, as it is recent, there is less follow-up and less the literature is available. Hmm. But if you're planning for full mouth rehab, you can definitely go with this transnasal technique along with the pterygoid and zygomatic implant. So one retrospective cohort study uh, evaluated 10 consecutive cases with mean follow-up of 1 year post-loading, has shown no failure rates and marginal bone loss. So marginal bone loss up to any implant around 1 to 1.5 within a year or 1.5 year about the pterygoid, zygomatic, and this transnasal implant is considered acceptable. If it is more than that, that means your stability might be lost in the future. The preliminary results suggest that transnasal implant achieve osseointegration and bone stability comparable to traditional implants when adequate bone engagement is confirmed radiographically. So, the transnasal I have explained already. So, I have skipped the images. The next is accuracy outcomes, guided versus freehand. Hmm? So, as we gone into the era of guided, hmm, the as we go more with the guided surgery, we have encountered less and less complications. Although there are some complication regarding how you are planning. If you are poorly planned your guide, then you will definitely under go complications or failure. If you are well with the guide but not executed properly implant placement, or your guide is moved somewhere else, or your guide slip breakdown during surgery, then you might encounter complications. Okay. So a comprehensive review of 41 studies published between 2018 and 22 established that computer-aided guided surgery achieves mean distance to deviation less than 2 mm, and angular deviation less than 8 mm, 8 degrees. So if you go with the guided, you have chance that you might be deviated from your actual planning by 2 mm or mostly 8 degrees. But in cases of freehand, the number increases significantly because you it consider your experience, your learning curve, your placement, and if the you have not the well versed with the technique and place implant, you will almost end up in complication. So these are the points to be taken from that study. It shows that in guided you will get less and less the deviation. In any other way, angular deviation is less, coronal deviation is there, the deviation is definitely there, but it is less as compared to freehand. So this is the chart showing the radiographic accuracy comparison with guided versus freehand. So the angular deviation is more in cases of your freehand technique. Okay, and it shows less with your the angular deviation is more with freehand, less with static guide. And the most significant deviation is angular deviation. And the coronal deviation is less in cases of static guide CAD-CAM technique, but almost comparable with each other in cases of freehand and multi-slice CT technique. And in CVCT guided technique, it also shows less variations. And out of this complex implant success rates over time, so immediately the success rate is 98%, but over a 5 years of period, the success drops down to 96% in cases of zygomatic implant, whereas it remains steady in cases of pterygoid and nasalis implant. as the nasal ACE implant has follow-up rate 1 or 1.5 years, it is considered initially 96%, but follow-up data is not